Hello, today's topic is physiology of labor. Prior to that, we'll be starting out regarding certain definitions. So, what is labor? Labor comprises of events that take place in the uterus and birth canal to expel the viable fetus through the vagina. What is delivery? Expulsion or extraction of a viable fetus out of the uterus is known as delivery. What is normal labor? Normal labor of eutosia is when a mature fetus presented by vertex is delivered by natural efforts unaided without undue prolongation of labor or complications to either mother or baby. What is dystocia? A difficult labor which refers to a labor not progressing satisfactorily with possibly undue consequences to the mother and the fetus. Now, onset of labor. How does labor start? The exact mechanism is not clear. The factors which involve the onset of labor are hormonal factors. Feto-placental contribution plays an important role. It has been seen due to unknown factors, fetal pituitary is stimulated prior to onset of labor. This causes stimulation of fetal adrenals, increase in cortisol secretion, which has a negative feedback effect on progesterone synthesis. This causes an alteration in estrogen-progesterone ratio, resulting in increased prostaglandin synthesis. Estrogen promotes the synthesis of oxytocin receptors in myometrium and deciduum, and it causes lysosomal disintegration, which causes increase in prostaglandin synthesis. Nervous factor. There is an increase in contractile response which is initiated through the alpha receptors of the postganglionic nerve fibers in and around the cervix and the lower part of the uterus. The stages of labor. Besides the classical 3 stages, a period of pre-labor and 4th stage has also been added. What are the changes in pre-labor stage? This begins about 2 to 3 weeks prior to the onset of true labor. The changes are: first, lightening. Formation of lower uterine segment allows the presenting part to descend, causing a lowering of fundal height and sense of relief for the mother. Second, there is increased vaginal secretion. Third, there is softening and effacement of the cervix. And false labor pain may occur in variable frequency. That comes us to the signs of true labor pain. What are the signs of true labor pain? First, the pain is felt in front of the lower abdomen. The painful uterine contraction are associated with an increase in frequency or duration, and these are associated with hardening of the uterus. There is appearance of blood-stained mucus discharge from the vagina. There is progressive dilatation and effacement of the cervix. There is the formation of bag of membranes, and there is simultaneous ascent of the head. Now coming to the changes which occur in the first stage of labor. First we come to the duration of first stage of labor. The first stage, it starts from the onset of true labor pain to the full cervical dilatation. It has a duration of about 12 hours in primary, while it is of 6 hours in multigravidal. The second stage, it again starts from the full cervical dilatation to the delivery of the baby. It lasts for 2 hours in the primary and 30 minutes in multi. The third stage is the delivery of the from the delivery of the baby to expulsion of placenta and membranes. It lasts for 15 minutes in both primary gravida and multigravida. The fourth stage is the stage of observation after the third stage for 1 hour to detect any post-delivery problems, for example PPH, uterine inversion, and vulvar hematoma. That comes us to our topic of today, which is physiology of labor. There are two forces which act mainly. They are the primary forces and the secondary forces. And the primary forces are the uterine contraction. Uterus as such has no pacemaker. The contraction starts from one cornual region and spreads downwards. The pain is distributed along the T10 and to L1, and it is caused by stretching and ischemia. The pain of cervical dilatation is referred to the small of the back, and it is referred through the sacral plexus. Now, during uterine contraction, the intrauterine pressure increases from about 20 millimeters of mercury initially and may go on to be about 40 to 50 millimeters during the first stage, to about 100 to 200 millimeters of mercury in the second stage. The baseline uterine pressure or tonus is about 8 to 10 millimeters of mercury. Uterine contractions, usually initially they last for less than 20 seconds. Then they might go on to be as much as more than 40 seconds. The frequency in which they occur initially 1 to 2 per 10 minutes, and then they go on to be about 4 to 5 contractions per minute. During labor, the uterine muscle exhibits the properties of contraction, relaxation, and retraction. So that brings us to what is retraction. Retraction is a special property of the upper uterine segment. There is progressive shortening of the uterine muscle fibers following contraction. It starts towards the end of the first stage and continues towards the second and third stage of labor as well. It results in the formation of lower uterine segment. It is also responsible for the cervical changes, and it causes advancement of the presenting part. Now, what are the secondary forces? These comprise of the contraction of the voluntary muscles of the abdominal wall. They help in reinforcing the uterine contractions to expel the fetus during second stage, and it is known as the bearing down efforts. What are the metabolic changes? The resultant metabolic acidosis due to labor is well compensated by the parturient or the laboring lady. Normal fetus has got enough reserve to withstand the physiological hypoxic state induced by contraction of labor. What are the change events which take place in the first stage of labor? First, as we have already discussed, they are the uterine contractions which increase in frequency and duration. Then, as I told before, there is a formation of cervical mucus plug formation, which is evident as the bloody show. Then the third point is the effacement of the cervix. This is a process of thinning out of the cervix with gradual shortening of the cervix. The cervix becomes papery thin when 100% effaced. Dilatation of the cervix, it progressively occurs starting from the internal os involving the cervical canal, and then it finally involves the external os. Dilatation, it is measured by finger breadth, but it is recorded in centimeters. Full dilatation of the cervix is of 10 centimeters. In multigravida, dilatation and effacement occur simultaneously, and thus it occurs rapidly. Now, formation of bag of waters. The presenting part causes the forewaters to bulge in a form of bag, and this ball valve action helps in the progress of labor. The hydrostatic action of the bag of membranes is found to be effective in progress of labor. Partograph is also known to be a cervicograph or partograph. It was first devised by Friedman in 1978, who represented it as a graphical representation of the events of labor, plotting cervical dilatation in centimeters against the duration of labor in hours, and it was found to be a sigmoid curve. The phase of first stage of labor is divided into the latent phase and the active phase. The latent phase is the phase till which from the onset of labor till the cervix is 3 cm dilated. It is found to last for about 6 to 8 hours in primi and 4 to 6 hours in multi. Prolonged latent phase is stated to be when this stage lasts for more than 20 hours in primi and 14 hours in cases of multigravidae. Now the active phase is the phase which starts from 3 centimeters of the uterus, of the cervix, till it is 10 centimeters in dilatation. This lasts for about 4 hours in cases of primi, while in cases of multi, it lasts for 2 hours. This is again further divided into an acceleration phase, a maximal slope phase, and a phase of deceleration. The acceleration phase is that which includes when the uterus in the cervix is 3 to 4 centimeters dilated. The stage of maximum slope is when it is 4 to 9 centimeter dilated, while the phase of deceleration is when it is 9 to 10 centimeters dilated. Friedman developed the concept of 3 functional divisions of labor. Active phase, that is the preparatory phase, the dilatational phase, and the pelvic division. The dilatational phase, it corresponds to the phase of maximum slope. That is the phase in which the dilatation occurs at a rapid rate and it is not affected by either sedation or analgesia. An important terminology which must be made in this topic is that of the lower uterine segment formation. The lower uterine segment formation occurs because of the contraction and retraction. During labor, there is a demarcation between the contractile upper uterine segment and the relatively passive lower uterine segment. This is more pronounced, especially in the late first stage, and attains maximum in the second stage. Junction of these two stage is marked by a raised ridge or ring, which is known as a physiological retraction ring. However, this ring in obstructive labor is found to be very prominent, oblique, and is known as pathological retraction ring or Dangel's ring. The lower uterine segment is important because it helps in the progress of the lower presenting part. It can be identified during cesarean section by the loose attachment of the visceral peritoneum, and if the placenta is attached in this lower part, it comprises of a special clinical entity which is known as placenta previa. Now coming to the second stage of labor. What are the events which occur in the second stage of labor? They are primarily comprised of the descent as well as the delivery. Delivery is helped by the contractions of the uterus as well as the bearing down effort on part of the mother. Now descent, it is found to be determined by both abdominal as well as vaginal examination. Abdominal means palpation of the head, the number of fifths which are palpable according to the Crichton method comprises of the abdominal palpation method, while vaginally, when you are examining the lady vaginally, the position of the relative position of the head with respect to the ischial spine denotes whether the head is engaged or not, and the progressive descent of the head. What are the events in the third stage? The events of the third stage are that of placental separation. This again occurs by rhythmic uterine contraction. The placental separation is characterized by marked retraction, which reduces the surface area of the placental site, thus helping in separation and controlling bleeding. The separation occurs by the shearing off of the placenta from the site of insertion. There are 2 ways of separation of the placenta. They are central or the Sulz method and the marginal method or the Matthew-Duncan method. After separation, the placenta is delivered physiologically by uterine contraction and retraction as well as the bearing down efforts. It can also be delivered by controlled contraction, which is a method which is adopted in case or as a part of active management of the third stage of labor. Bleeding control is usually done by retraction of the retraction of the uterus, which creates a pressure on the interlacing of the retraction. It affects the interlacing muscle fibers of the uterus. These clamp the uterine vessels which run in between them. Along with this, thrombosis and apposition of the uterine wall also helps in minimization of bleeding. In the third stage of labor, the normal amount of bleeding is usually about 100 to 300 milliliters, and it may be more than 500 milliliters in cases of PPH. That is all we have to discuss about physiology of labor. I will advise you to just go through your books, and I'm sure it will be any other problem you face regarding this topic will be clear once you go through the books. Thank you.